So good evening, everyone, and welcome to this weekend's tutorial. And we're going to be talking about a very, very important subject, which is key to our practice as an anesthetist. I have 128 slides, and I'm sure there's no way we can finish it. I attempted to try to bring in as much as possible because pain is central to our practice. But we'll see how we go about it. I'm sure maybe it can take us like 3 sessions to finish, but we'll not rush it. So just see how far we can go. All right, so this will be our learning outcomes. The title is Pain, Acute and Chronic. So at the end of the discussion, I expect all of us to be able to define acute and chronic pain and describe their clinical significance, to be able to explain the pathophysiology of acute and chronic pain, including mechanisms of sensitization, differentiate between acute and chronic pain, should be able to apply different pain assessment tools in various patient populations, including ICU patient. You should be able to describe the principles and components of multimodal analgesia. All right, outline pharmacological and non-pharmacological strategies for managing acute pain. Describe approaches for the management of chronic pain, and identify challenges of pain management in special populations. All right, so these will be our goals, and we'll follow this outline. So quickly, let's see how far we can go with our questions today. So the first question is, you have a 65-year-old patient, okay, in the ICU after an open abdominal surgery, is mechanically ventilated and receiving continuous sedation with with propofol. His blood pressure is stable, but he's showing signs of grimacing and tachycardia during suctioning. All right, so which is the most appropriate next step for pain management in this patient? Anyone?
B.
B is correct. B is correct. Okay. I hope we all agree with that. B is correct. Okay. A 40-year-old patient with CKD stage 4 is admitted for major abdominal surgery. Which of the following analgesic strategies is most appropriate post-operatively, all right, to minimize the risk of toxicity? Note that this patient is a CKD stage 4 patient. So A, morphine, patient control analgesia standard dose, tramadol PCA standard dose, fentanyl with PCA, fentanyl PCA with dose adjustment, NSAID every 8 hours, Betadine infusion. Which of the following way is the most appropriate?
C.
C.
C. C. All right. I think I gave that question away. I should have removed with those adjustments. Okay. Smart guys. All right. 3. A 55-year-old male trauma patient in the ICU has multiple rib fractures and is on high flow oxygen. He complains of severe chest pain, VAS score of 8/10, despite being on IV morphine. What would be the best next step to improve pain control and respiratory function in this patient?
C.
C, correct. Initiate thoracic epidural, correct. 4. A 70-year-old patient underwent hip replacement surgery. On the first day post-op is confused, hypoxic, and has a respiratory rate of 8 breaths per minute after repeated doses of morphine for pain control. What is the most appropriate immediate management for this patient?
A.
A.
You won't stop morphine and observe? A is correct. I agree. Sorry? Did
Yes,
somebody
A.
say B?
No.
A. The answer A, Prof. A.
A is correct. A is correct. A 60-year-old female patient with severe pancreatitis on mechanical ventilation in the ICU. She's receiving high-dose opioid for pain control, but develops increasing sedation and constipation. What is the best opioid sparing strategy for this patient? Quickly.
B.
What? I can't hear that answer.
A.
Okay. A, any other answer apart from A?
B.
B.
B. B is correct. I'll take B.
B.
B is correct. All right. How does ketamine work? Which receptors does ketamine work on? Anybody?
NMDA
On the
receptors.
NMDA receptors.
Beautiful.
Receptors.
I'm proud of you guys. You guys are doing well. I'm proud of you. Okay. This short answer question. A 60-year-old male patient is in the ICU after a major abdominal surgery. He's sedated and on mechanical ventilation. So what is the most appropriate method to assess pain in this patient? 2. Why is propofol infusion alone inadequate for analgesia? C. Name 2 opioid drugs commonly used for pain in ventilated ICU patients. D. List 2 opioid sparing strategies suitable for this patient. And E. Mention 1 major adverse effect of opioids in ICU patients. We'll not attempt this. I'm just giving you something to think about. Okay? Rack your brain. Then if we're able to finish this first session, we may come back to it. Okay, so pain, very big subject to tackle. All right, so pain is an unpleasant sensory and emotional experience that is associated with actual or potential tissue damage. All right, this was the definition given by the International Association for the Society of Pain. But note that whatever it is, pain is subjective, all right? And it is whatever the patient says it is, all right? If the patient says I'm in pain, you can't say the patient is lying. So existing wherever the experiencing person say it does. So number 1, whatever the person says it is, all right? And wherever the person says is feeling it. And that is why pain, all right, pain management has multidimensional approach. So pain has also been described as a 5th vital sign as far back as more than 2 decades ago by the American Pain Society. So what this means is that assessment of pain should be routine, just like temperature, pulse rate, respiratory rate, and blood pressure measurement. So our nurses should be involved in monitoring and documenting pain as a vital sign. So since we are looking at acute and chronic pain, we quickly want to make a distinction here as we go on. So acute pain refers to pain of sudden onset. Usually, it is related to injury, surgery, or acute illness, but not lasting more than 3 to 6 months. Some people give, 6 months. Okay. Chronic pain, on the other hand, is described as pain that persists beyond the normal tissue healing time, generally more than 3 months or recurring more frequently. So this is the major difference between acute and chronic pain by way of definition. But we'll see more of it as we go in the course of this study. All right, there are various terms that are used in describing pain: allodynia, All right, this is when a patient feels pain from an ordinary non-nauseous stimuli. Analgesia is when there's no pain, absence of pain perception. Anesthesia refers to absence of all sensations. And when you have anesthesia dolorosa, this is when a patient feels pain in an area that lacks sensation, an anesthetized area, and the patient still feels pain. Dystasia, hyperalgesia, and all of that. So there's different terms that are used to describe pain. So epidemiology and clinical relevance. Acute pain is common post-operatively, and that's where we come in trauma, especially in emergency units. And it's also very common, usually underdiagnosed among ICU patients. Painfully, about 10 to 50% of our post-op patients will develop chronic pain, what we know as post-surgical chronic pain syndrome. This is from undertreatment of acute pain, especially in the post-op period. And the patient goes on to develop what we know as a post-surgical chronic pain syndrome. All right, management of pain in ICU is challenging because most of our patients are sedated. They are unable to self-report the degree and intensity of their pain, and this all leads to a high risk of undertreated pain. So let's look at the pathophysiology of pain. All right, so there are 4 different ways, all right, to describe the pathophysiology of pain. Okay, let me see if I can have the diagram so that, yes, let's look at it from here. Okay, there are 4 different, pathways to describe the pathophysiology of pain. So we have transduction, transmission, modulation, and perception. Transduction, this is when the nociceptors in the skin and other peripheral tissues, all right, activated by different noxious stimuli, pain, heat, mechanical, and all that, okay? And this is mediated by your prostaglandin E2, your substance P, bradykinase, and interleukins, okay? So transmission is when this pain is transmitted by pain nerve fibers. Most of the time, the A delta and AC fibers, all right? And they're transmitted, we're going to look at it through different neurons, the first, second, and third order neurons. All right, and it goes through the tract, we're going to see that, and go through modulations. Modulation takes place in the spinal cord, in the substantia gelatinosa. Okay, as you can see here, modulation can either be excitatory or inhibitory, all right? What it means is that the pain can be made worse or it can be inhibited. Okay, so this modulation takes place at the level of the spinal cord, at the substantia gelatinosa. Then from there we have the brain perception. This is where the patient experiences the pain. Okay, and this is from the thalamus and the cortex. So this is just the diagram to explain 4 slides that we've talked about. Okay, do we understand that? All right, so this is just what I've just talked about. I'm sure by the time you see that, we'll see. And the importance of looking at the pathophysiology are the drugs acting at different level. Okay, we have at the transduction, we have the non-steroidal anti-inflammatory drugs acting at that level. Okay, the local anesthetic agent. Okay, steroids and all that at this level. Okay, transduction or transmission, look at anesthetic, gabapentinoid, and all that at that level. Okay, at the modulation, we have opioids. All right, actin and alpha agonist. Okay, and then the perception, this is where general anesthetic agents, sedatives, and other psychological interventions add. Okay, so the next thing we're going to look at is nerve fibers. Okay, and these are, fibers that transmit pain sensation along the different tracts. So we have the different types based on their sizes in diameter and the rates of transmission. So we have the A fibers, A alpha fibers. These are large diameter myelinated fibers, big diameter 13 to 20 microns, and they'll have a speed of about 80 to 120 meter per second rather. Okay, so they're involved in motor proprioception. They are not actually involved in pain transmission. They're only just on touch and pressure. The A beta fibers are also large diameter myelinated fibers, all right, with diameter of 6 to 12 micrometer, all right, velocity 35 to 90 meter per second, all right, they function in touch and pressure, all right. So the A beta fibers also do not transmit acute pain, although they may be involved in neuropathic pain. So the two fibers that we're interested in as an institute are those that are responsible for what we know as the fast or slow pain, all right, which is common with acute pain. So the A delta fibers are small diameter, thinly myelinated fibers, all right, with a very small diameter, 1 to 6 micron, with a very low velocity of conduction, 5 to 40 meters per second. All right, they function for sharp and well-localized force pain. The C fibers are small diameter, also unmyelinated, and because of that, they have a very slow conduction rate, actually the smallest, 0.4 to 2 meters per second, and they function for dull, morning, and throbbing second pain. Okay, so this is just a table to show you the different, nerve fibers that I've just talked about. So classification of pain. Pain may be classified based on duration, based on pathophysiology, based on the location, and based on the etiology. So based on duration, pain can be classified as acute or chronic, like we mentioned before. So, and based on pathophysiology, pain can also be classified as nociceptive pain or neuropathic pain. It's important to distinguish between these two because nociceptive pain are activated by nociceptors as a result of actual or potential tissue damage. And we have two subtypes of nociceptive pain, the somatic and the visceral pain. The neuropathic pain, on the other hand, is caused by damage or dysfunction in the peripheral nerves or CNS. Examples include posthepatic neuralgia. We have the diabetic neuropathy. Right? This pain is characterized by burning or shooting sensation, sometimes tickling or electric shock-like pain. All right, pain based on location. We can have superficial or deep somatic pain, okay, or visceral pain, all right? Superficial cutaneous pain arises from the skin or subcutaneous tissue. This is the kind of pain you have from lacerations or burns, especially first or second degree burns. Deep somatic pain, these are pains that arise from muscles, joints, and bones, arthritis or fractures. Visceral pain are these that result from stretching of internal organs. All right, this also may be represented by referred pain. All right, the pain of MI that is referred to the arm. Based on etiology, cancer pain, as the name suggests, we have post-op pain related to surgery, trauma, all right? And we have procedural pain. Sometimes pain that comes with endoscopy and all those ones, we sometimes refer them as post-op, but ideally, they are procedural pain. Okay, so we have two types of pain we mentioned before that are mediated or transmitted by different types of fibers. The fast pain, also known as the forced pain. This is the pain a patient feels upon injury, all right? And it's mediated or transmitted by the A-delta fibers, okay? So it's rapid, immediate sensation. Okay, it could be sharp or pricking, and it's well localized. You can localize where it is. And the function is that the forced pain protects, all right, activates the protective reflexes. And that's why you can rapidly withdraw your hands from a hot object. Okay, so this can result from needle prick, cut, or burns. Slow pain, or what we know as the second pain, is transmitted by the C fibers, all right, unmyelinated, all right. There is some delay, some seconds after contact with the noxious stimulus. Usually dull, aching, throbbing, all right, and it's prolonged. So what second pain does is that it promotes protective behaviors, all right? So next time you come across that noxious stimuli, you remember the pain, okay? The first or fast pain elicits, protective reflexes. Why? This one gives you protective behaviors. You don't want to come across or do the same thing. Some patients, one of the, from a lot of studies that have been done, pain is usually one of the reasons why a lot of patients fear surgery, because especially those who have had surgery before or those whose friends or relatives have had surgery, is a result of slow pain or what we know as second pain. All right, so this is a table that differentiates between fast and slow pain. I hope I'm not too fast. Are you following me? Am I too
Yes.
fast?
No.
No.
Yes.
Okay. So pain neurotransmitters and transmitter neurons. Okay. So let's quickly look at the role of prostaglandins in pain perception or pain transduction. Mutually, it's pain transduction. So prostaglandins play a critical role in the pain pathways, like I showed you before, primarily during sensitization and amplification of pain signals. So prostaglandin E2 and prostaglandin I2 are lipid compounds that are derived from arachidonic acid through the cyclooxygenase pathway. Okay. So when a tissue or a tissue injury inflammation occurs, this leads to activation of phospholipase A2, which releases arachidonic acid. This arachidonic acid is then converted by two enzyme system, COS1 and COS2, to prostaglandins. So this prostaglandin is that neurotransmitter just that activates, that's as the peripheral mediator, all right, of your nociceptors, just at transduction, all right, if you remember the pain pathway we talked about. So pain neurotransmitters could either be excitatory or inhibitory, excitatory or facilitatory. All right, there are different pain neurotransmitters. All right, I call them the ABG. Okay, ABG, aspartate, glutamate, A, aspartate, B, bradykinins, G, glutamate, then substance P, and prostaglandin. So I call them the ABGs of pain. Okay, so the glutamate is the primary excitatory neurotransmitter in the dorsal horn of the spinal cord. All right, glutamate neurotransmitters are released by your primary pain fibers, the A, delta, and C fibers in the dorsal horn. And we're going to be looking at the different lamina of the spinal cord. I hope we get there today. All right. So this glutamate acts on your NMDA and APA and kinase receptors, which causes depolarization of your second order neurons. Okay. So release of glutamate causes rapid transmission of your first pain or the first pain. The second one we're talking about is substance P. Remember that glutamate is an amino acid. So glutamate and aspartate are amino acid neurotransmitters, while substance P, all right, and bradykinin and neuropeptides. So substance P is a neuropeptide that is released visually by C fibers, okay, for slow burning pain. They bind to neurokinase 1 receptors on second order neurons. They help to promote and prolong pain signal, especially those involved in neurogenic inflammation, okay, usually associated to hyperalgesia and chronic pain. Okay, so there's another excitatory one, the calcitonin-related peptide. It's a neuropeptide, okay? It's co-released with substance P from C fibers, also helps to potentiate pain transmission and contributes to migraine pathophysiology. All right, these are very important single-based MCQ questions. Single-based questions, yes. So aspartate also works alongside glutamate. Don't forget that they are both amino acids and they help in promoting polarization and pain transmission. Inhibitory neurotransmitters are the gamma and the glycine, serotonin, and your norepinephrine. Okay, so GABA is located in the interneurons, all right, in the dorsal horn, and it activates the GABA A and GABA B receptors, causing hyperpolarization. So it's inhibitory ascending pain signals, all right, so GABA is inhibitory. Glycine works alongside with GABA to inhibit postsynaptic neurons in the dorsal horn, and it helps to maintain excitation and inhibition of pain transmission. So endogenous opioids like your enkephalins, endorphins, and dynorphins, all right, these bind to your mu, delta, and kappa opioid receptors in the spinal cord and brings them, all right, and they reduce neurotransmitter release, especially those excitatory neurotransmitter release, your substance P, glutamate, aspartate, and all that. So they hyperpolarize neurons and activate the descending inhibitory pathways. Serotonin, all right, located in the descending pain modulatory pathway, especially from the raphe nuclei. They help to facilitate or inhibit pain depending on the receptor subtype. All right, so modulation of pain, targeted serotonin receptor inhibitors in chronic pain and all that. So this is a diagram, a table that show you the different types of pain neurotransmitters, okay? So you do well if you go through them, okay? And this is just it, another table to just highlight all I've been talking about. Note that substance P, prostaglandin, aspartate, bradykinin, and glutamate, they are pain excitatory neurotransmitters. We call them pain initiators, all right? Why serotonin, endorphin, enkephalins, endorphin, enkephalin, and dynorphins, endogenous, endogenous, okay, and they are pain inhibitors, okay. Your glycine and your GABA are the other neurotransmitters that serve as pain inhibitors. Okay, so we look at the transmitter neurons, and like we said, we have 3 different types. The first order, the primary neurons, these are located peripherally with the nociceptors, and this transmits pain sensation from the peripheral nociceptors to the dorsal horn of your spinal cord. Okay, there are two types of them. We mentioned them before: A delta fibers and C fibers. All right, the function of the first order neurons is the detection of noxious stimuli, be it mechanical, thermal, or chemical, and this converts these noxious stimuli into electrical impulses, and that's where transduction takes place. Okay, neurotransmitters are now released at the dorsal horn, which most of the time are excitatory, like we mentioned. Okay, the clinical importance of first order neurons is that they are targeted by your local anesthetic agents, which block freedom channels, and also the NSAID, which help to reduce the formation of prostaglandins, reducing peripheral sensitization. Well, the second order neurons, all right, these are located at the dorsal horn of the spinal cord and helps to transmit pain sensation from the spinal cord to the thalamus through the spinothalamic tract. All right. So neurotransmitters release glutamate, all right, substance P, and here modulation takes place with interneurons releasing inhibitory neurotransmitters. All right, the clinical relevance here is that this is where your opioids, okay, work by binding mu receptors on presynaptic and postsynaptic neurons, inhibiting the release of excitatory neurotransmitters. The third order neurons are those in the thalamus, all right, and all the other regions where pain perception takes place, your somatosensory cortex and limbic system. They are responsible for perception of pain, including sensory, discriminatory, and affective, which is the emotional aspect. All right, a lot of neuromodulators work here, the excitatory and the inhibitory, with your endogenous opioids, your endorphins, dynorphins, your enkephalins. All right, at this point, this is where your general anesthetics, sedatives, work by reducing conscious perception of pain. And the trick here is that pain sensation is present, but the ability of the patient to perceive pain has been modulated. Okay, and this is where other chronic pain, maneuvers like your psychological and cognitive therapies also help by working on the thalamus via the third order neurons to modulate cortical perception of pain. Okay, so this table gives you the different types of the transmitter neurons, first order, second, and third order neurons. Okay, we'll talk about some of these receptors. We mentioned them before. Okay, the NMDA receptors are a type of glutamic receptors in the CNS. Okay, they are primarily located in the dorsal horn of the spinal cord and also in the thalamus. Okay, note that when nociceptors release glutamate and substance P at the dorsal horn, all right, under normal conditions, these NMDA receptors are blocked by magnesium ions, but persistent or intense stimulation causes this magnesium blockage to be removed, leading to receptor activation and the release of calcium ions into the postsynaptic neurons. The enhanced calcium inflows leads to amplification of your pain sensation. All right. Centrally, they can lead to what we know as the wind-up phenomenon, where repetitive stimulation can cause amplified pain response. And this is where you have your hyperalgesia or allodynia. You remember allodynia that we mentioned in our previous slides. We have the alpha amino 3-hydroxy 5-methyl 4-isosaproponic acid. I'm biting my tongues, guys. All right. So what it does is this: the alpha mediated depolarization, all right, apart from leading to sodium inflows, helps to remove the magnesium ion blockage from NMDA receptors, all right, enhancing the activities of your NMDA receptors, enabling central sensitization as stimulation persists. The neurokinin 1 receptors are G-coupled, G-protein coupled receptors, and they primarily bind to substance P. They play a key role in modulating pain signals, all right? And this also repeated, sorry for that noise, oh my God. Okay, repetitive activation promotes hyperalgesia and allodynia. Sorry for that, I'm presenting outside. Okay. Oh my God, can you hear me? Sorry for that disruption, can you hear me?
Yes, Prof.
We can hear you.
This guy's okay. So let's quickly look at the spinal cord lamina. I need to go in. Okay, spinal cord lamina. Let's ignore it. So they remember the spinal cord has white and gray matter. The gray matter of the spinal cord was divided into 10 lamina some time ago by rest. So they are also called the rest lamina. Give me a minute, I'm moving inside. All right, so the gray matter of the spinal cord is divided into 10 lamina, all right, by rest. So they're also known as the rest lamina, all right? And we're going to look at them as we continue. The lamina 1 to 6 form the dorsal horn of the spinal cord, all right? And this receive all afferent neural activities and represent the primary site of pain modulation by ascending and descending neural pathway. Lamina 2, also known as the substantia gelatinosa, all right, this is of importance to us as anesthetists, all right, contains many interneurons and is a major site of action for opioids. Lamina 5 contains the wide diverse range neurons, and this is what is responsible for referred pain. We're going to look at the different lamina as we go on, but these three parts are very important for you to remember. Lamina 1 to 6 form the dorsal horn. Lamina 2 is also known as the substantia gelatinosa, which contains many interneurons and is the major site of action for opioids. And lamina 5 contains the WDR neurons. Okay, so this is breaking it down. Lamina 1, also known as marginal zone. This is the most dorsal part of the dorsal horn. All right, projection neurons to contralateral spinothalamic tract. Okay, receives input from A delta and C fibers. The lamina 2, like I mentioned, is below the lamina 1, also known as substantia gelatinosa. This contains a lot of interneurons. Okay, major site for C fiber input, and the modulation takes place here via the interneurons. And this is where your gate control theory also applies. The key neurotransmitters at this level are the substance P, glutamate, and enkephalins. The lamina 3 and 4 are the nucleus proprius. All right, this receives non-nociceptive A delta fibers, all right, and they can modulate the nociceptive signals via inhibitory interneurons, your touch pain interaction. Lamina 5 receives convergent input from different neurotransmitter fibers, the A delta, C, and A beta fibers, and is important for the wide dynamic range neurons all right, which process both noxious and not noxious stimuli, and is the basis for referred pain, like the pain of MI, myocardial infarction. Laminar cyst is involved in proprioception and all that. Okay, because of our time, laminar 10 surrounds the central canal, the spinal cord, and contains neurons for visceral pain and commissural connections. Okay, so we have what we know as the primary pain pathway, and we have the alternative pain pathway. Okay, so the primary pain pathway, number one, is the spinothalamic tract. Okay, this is a key ascending pathway. If you remember the diagram we looked at before, the spinothalamic tract is a key ascending sensory pathway in the spinal cord, which is responsible for transmitting pain, temperature, and crude touch sensations to the brain. So you have pain, okay, temperature, and crude touch, okay? It is formed by the axons of the second order neurons, if you remember, and which cross the midline close to the origin of the neurons to the contralateral side. So these strands send fibers to the thalamus, the reticular formation, the nucleus raphe, and the periaqueductal gray matter. Okay, remember, or always remember that they are divided into the lateral and the medial spinothalamic tract. The lateral spinothalamic tract projects into the anteroposterior lateral nucleus of the thalamus, and this is what is responsible for the discriminative aspects of pain. This is what is responsible for the patient able to localize where pain is, how long the pain is, and it's also responsible for thermal sensation. The medial part of the spinothalamic tract projects to the medial thalamus and is responsible for mediating the autonomic and unpleasant emotional perception of pain, touch, and pressure. All right. So we have alternative pain pathways, the spinal-reticular tract and the spinal-mesencephalic tract. Okay. And this is just for you to know. Okay. You can read that up, but the major pain pathway is the spinothalamic tract, and the alternative pathway. What it means is that pain can actually be transmitted through these routes, even though they are not the main ones. Okay. We have spinal hypothalamic, spinal limbic pathway. These are different alternative pain pathway. Now let's come to this popular theory known as the gate control theory of pain. The gate control theory of pain. Now this was proposed as way back as 1965 by Mensack and Wall, all right? And it asserts that non-painful inputs can close the nerve gates to painful inputs, preventing pain sensation from traveling to the central nervous system. Let me repeat that. Mensack and Wall proposed that there is a gate, especially in lamina 2 of the spinal cord, all right, which allows pain transmission or prevent pain transmission. So whatever activates that gate system will determine whether the patient will feel the sensation of pain or not. So the key concept of the gate control theory of pain is that pain signals from the periphery, from your nociceptors, from your primary or first order neuron, must pass through a gate mechanism in the dorsal horn of the spinal cord before it reaches the brain. And don't forget that it is in the brain that you have perception of pain. So it proposes that this gate can be opened or closed by the relative activity of different nerve fibers and descending pathways. Okay, So the location of the gate is the substantia genitalosa, that is the lamina 2 of the dorsal horn of the spinal cord, and the gate is controlled by different fiber types. Small data fibers like the A data and C fibers carry pain signals, all right, and they open the gate. So small diameter fibers cause opening of the gates, and this will cause pain to be transmitted to the brain, the thalamus, and your somatosensory cortex, and the limbic system. Large diameter fibers, on the other hand, carry no painful touch or pressure signals, and their function is to close the gate, so inhibiting pain transmission from reaching the brain. Descending control from the brainstem also helps with the control of the gate. Endogenous inhibitory pathways like your serotogenic, your norepinephrine, and opioidogenic a pathway can close the gate by inhibiting pain transmission at the dorsal horn of the spinal cord. So why is the gate control theory of pain very significant? All right. It explains why when you have an injury to your skin, you rub that part of the skin, all right, you're activating your large diameter fibers, your A beta fibers. So what you're doing is that you are closing the gate at the substantia gelatinosa lamina 2 of the spinal cord. So pain perception is inhibited because pain is not allowed to be transmitted through the gate to the higher centers. All right. It's also the basis for other therapies like your transcutaneous electrical nerve stimulation, your spinal cord stimulation, massage, and physiotherapy. All this depends on the great theory of pain by stimulating or activating large diameter fibers, leading to inhibition of pain transmission through the lamina 2 of the spinal cord. Now, this is what we're talking about here, okay? I hope you can see that. So the small diameter fiber causes the gate to open. So there's transmission of pain stimulus from the spinal cord to the brain, while large diameter fiber causes a closure of the gate, so transmission does not work. Okay, I think we have 7 minutes. Okay, let me quickly talk about this so that we can ask some questions. So we talked about the definition of acute and chronic pain. We did say that pain can be categorized based on duration. So we have the short-term pain, which is acute pain, lasting less than 3 months or until tissue healing occurs. So when healing occurs, pain perception should also cease. For chronic pain, this is a pain that is lasting more than 3 to 6 months, all right? And it also refers to pain that exceeds beyond the expected healing period. All right. So you have chronic back pain. The injury had occurred maybe 6 months or 1 year ago, and the tissue injury tissue healing should have occurred, but the sensation of pain. So this leads to chronic pain. Okay. So there are different types. I mentioned the differences. Okay. Onset and timing. Okay. Acute pain is sudden and is of a short duration. Why chronic pain is usually insidious in onset and they last longer. For acute pain, there's always a warning signal of an actual or potential tissue damage. Okay? While in chronic pain, there's no warning signal of damage. All right? There's always a false alarm because there's no actual potential damage. Okay? Severity of acute pain correlates with the amount of tissue damage. Okay, the more tissue damage or during the post-op, the more surgical tissue handling during surgery, you expect more pain. So that is acute pain. But for chronic pain, all right, the pain is usually not related to tissue damage. In acute pain, the CNS is intact. Pain is just a symptom. Why chronic pain? The chronic pain itself becomes a disease due to the dysfunctional CNS involvement. All right, it's in acute pain, there's less psychological effect, there's less anxiety. Okay, lack of sleep usually relieved with pain is usually relieved with pain relief when the pain is taken care of, the patient sleeps. And that's why insomnia can be a sign of inadequate or undertreated acute pain. For acute chronic pain, this usually associated with depression, fear, anger, lack of sleep. And when we look at more chronic pain, you'll see the psychological and mental aspect of chronic pain. Okay, so nociceptive pain and neuropathic pain. Okay, nociceptive pain, this is well localized, while neuropathic pain is not well localized. Nociceptive pain is sharp, is worse with movement. And those of you who are interested in doing, your dissertation project on pain, you need to know the difference between pain at rest and pain of movement, because analgesic requirement differs. All right, but when there is pain score less than 4/10 on movement, that talks about adequate pain management or adequate analgesic therapy. All right, so nociceptive pain usually works with movement, while neuropathic pain is burning, shooting. All right, it feels numb with pains and needle sensation. All right, nociceptive pain, there is usually obvious tissue injury or illness or inflammation, while neuropathic pain, tissue injury may not be obvious. All right, but it's due to nerve injury resulting from changes in wiring or abnormal firing. Nociceptive pain is physiological, while neuropathic pain is pathological. All right, I think we should stop here today. And next time we'll look at pain assessment. Okay, and before we go to pain management, then we'll talk about chronic pain. So I think we should stop here. Colleagues, any question, any contributions, any reactions? Let me stop recording.